Hi everyone, I'm Shreyas Kalantri, a Hematology Oncology Chief Fellow at the University of Louisville Brown Cancer Center. So if there was one theme at this year's GU ASCO, it was this: can we do more for our patients earlier, and is the trade-off worth it? Across bladder, kidney and prostate cancer, we got some compelling answers. And I'm going to take you through the 4 trials I think that mattered a lot. So let's start with the one that had the room buzzing. For over 20 years, we have been giving cisplatin-based neoadjuvant chemo before cystectomy for muscle-invasive bladder cancer. It's worked, but it hasn't changed. Keynote B15 just changed it. This was a trial with 808 cisplatin-eligible patients, which were randomized to either Perioperative Enfortumab vedotin plus Pembrolizumab or standard neoadjuvant cisgem. And the AV Pembro arm didn't just win, it won convincingly. The EFS was with a hazard ratio of 0.53. OS had an hazard ratio of 0.65. But what really turned heads was the pathological complete response rate, 56% versus 33% in the intention to treat population. And if you look only at the patients who went to surgery, 64% in the AV Pembro arm. Now, you have to acknowledge the design. The AV Pembro arm gets over 6 months of cytotoxic therapy plus about a year of Pembrolizumab. The cisgem arm gets 3 months and then observation. So we are comparing patients who got longer treatment to less treatment. Grade 3 or higher events were somewhat higher in the combination arm, but the surgical completion rates were similar and no new safety signals emerged. Here's why this matters clinically. Paired with Keynote 905 data in the cisplatin ineligible patients, this is the first time a non-platinum regimen has outperformed cisplatin-based chemo head-to-head in the muscle-invasive bladder cancer. That's a sentence we have never been able to say before. And those PCR rates are going to accelerate an already growing conversation about bladder preservation. If nearly 60% of the patients have no viable tumor left at cystectomy, can some of them keep their bladder? Trials are already underway, and I think this will be one of the most exciting areas in GU oncology over the next few years. Now switching to kidney cancer, where the theme of intensification played out in 2 different settings. Both trials tested belzutifan, the first-in-class HIF2 alpha inhibitor, but one asked whether we can prevent recurrence better, and the other asked, what do we do when standard therapy stops working? LightSpark 22 tackled the adjuvant space. We know from Keynote 564 that adjuvant Pembrolizumab improves disease-free and overall survival in high-risk clear cell RCC, but roughly 40% of the patients still recur within 5 years. So this trial added belzutifan to Pembrolizumab and tested it against Pembro plus placebo in 1841 patients. The combination improved disease-free survival with a hazard ratio of 0.72, a significant 28% reduction in recurrence risk. The curve separated early and stayed separated even after treatment ended. Now that's encouraging. So here's where it gets complicated. The OS data are immature. Only 29% of the expected events and not yet significant. And these are the disease-free patients we are adding side effects to. Belzutifan causes anemia in nearly 84% of the patients, and a quarter needed treatment interruptions. Hypoxia occurred in 7%, some of it grade 3. So the conversation with your patient becomes, I can potentially reduce your risk of recurrence, but you are going to potentially have some side effects from this treatment. And we are not able to promise that you will have an overall survival benefit. So that's a real shared decision-making moment. So LightSpark 11 addresses the other end of the spectrum. Patient with metastatic RCC progressing after anti-PD-L1 therapy, which is now our most common clinical scenario. There's been no randomized phase 3 against a modern comparator in this space until now. So 747 patients were randomized to belzutifan plus lenvatinib versus cabozantinib. The combination bore on PFS hazard ratio of 0.7. The median PFS was 14.8 versus 10.7 months. Response rate was 53% versus 40%. But what stood out to me was the duration of response, 23 months versus 12. Now that tells you there's a subset of patients getting real durable benefit from this combination. OS trended favorably but didn't reach significance. And this is a 2-drug regimen. 2/3 of the patient needed lenvatinib dose reductions. The IMDC poor risk subgroup didn't seem to benefit based on the subgroup analysis. which echoes a pattern we saw in LifeSPAR 22 as well. So the takeaway is, this is a meaningful new option for post-PD-L1 RCC. Again, the right patient matters. And it seems that favorable and intermediate risk patients appear to gain the most. Finally, prostate cancer. And I think this trial does deserve a little bit more attention than it got. Phase 3 randomized 446 patients with bone-predominant metastatic castrate-resistant prostate cancer. Asymptomatically or mildly symptomatic patients were enrolled to either enzalutamide alone or enzalutamide plus 6 cycles of radium-223. With nearly 5 years of follow-up, the combination showed a statistically significant overall survival benefit. Hazard ratio was 0.76 with a median OS of 38.2 months versus 32.6 months. Now that's a 5.6 month improvement. Radiographic PFS was also confirmed with a hazard ratio of 0.71. Now the critical here is that this population isn't contemporary. Most of our metastatic CRPC patients today have already been on AR pathway inhibitor since the hormone-sensitive setting. Now that's fair. The OS curves also cross around 18 months and the benefit was attenuated in patients over 75. The grade 3 drug-related events were higher in the combination arm, 29% versus 19%, and there were rare secondary hematologic malignancies and cases of jaw osteonecrosis, making bone protective agents essential. But here's the thing. The discussion Dr. Yu meant a good point. I think it's exactly right. Achieving a statistically significant overall survival benefit is one of the hardest things to do in oncology. When we get one, our instinct should be to be able to figure out how to use it, not to explain it away. This regimen is already category 2A in NCCN guidelines for the first-line metastatic CRPC with bone metastasis, and it gives us the opportunity to bring radium-223 earlier in the disease course, and rather than reserving it with heavily pretreated symptomatic patients where it often used too late. So that's GU ASCO 2026, a year where the question was consistently, can we do more? And the data largely said yes, but with the caveat that patient selection is important. EB Pembro is rewriting the playbook in bladder cancer. Belzutifan is taking out territory across the kidney cancer continuum, and radium-223 earned us a seat earlier at the prostate cancer table. Now, thank you for watching, and this was a pleasure discussing GU ASCO data with you today.